I'm Terry Grebe from Genetics, and I'm very pleased to introduce our invited speaker today, Dr. Jennifer Yang. Dr. Yang is an assistant professor of neurosciences and co-director of the Neurometabolic and Mitochondrial Disease Clinic in the Division of Pediatric Neurology at UC San Diego and Rady Children's Hospital, San Diego. She completed her medical degree at the University of Alabama, Birmingham, her child neurology residency at UC San Diego, where she served as chief resident, and a fellowship in neuroimmunology and neurometabolics at UC San Diego and Rady Children's Hospital. Dr. Yang has formal training in clinical research methods. She specializes in the clinical management of primary mitochondrial disease, which we're going to talk about today, and genetic white matter diseases. Additionally, she sees pediatric patients with autoimmune and demyelinating disorders. She is a PI and co-investigator in several observational and investigator-initiated studies and industry-sponsored clinical trials in mitochondrial myopathy, Lee syndrome, MELAS, leukodystrophy, autoimmune encephalitis, and pediatric and adult multiple sclerosis. Please welcome Dr. Yang.
All right, thanks everyone coming in person and online. So today I'm going to give you an overview of mitochondrial disorders, go over the clinical phenotypes, and a little bit of the treatment landscape. It's a lot to cover, so it's going to be a bird's eye view on mitochondrial disease. These are my disclosures. So here's the landscape for today. Okay, we're going to go over the background. Don't worry, there won't be too much biochemistry. We'll go over the basics, and then we'll go over some of the mitochondrial disorders that you may see in the clinic and inpatient, and then talk a little bit about treatment at the end. So first background, so what is mitochondria? Put this up so you don't start snoozing already. So this is my Star Wars reference, all right? For those of you, this is a deep cut from Phantom Menace. But mitochondria, it's two words. So it's from the Greek word mito for threads and chondria for grain. So it's what someone named when they looked at the mitochondria a long time ago under the electron microscope. They are subcellular cytoplasmic organelles, and if you remember from high school biology, they used to be sulfur-producing bacteria that at some point developed a symbiotic relationship with eukaryotes. So this is George Lucas stealing this idea and forming the midichlorians of the Star Wars world. But we have real midichlorians here. So first poll question, if you guys have this, if the QR codes show true or false, mitochondrial disease is exclusively maternally inherited and caused by mutations in the mitochondrial DNA.
That's one. Yeah, then wait.
Yep.
Actually, I think you can advance one more, and I think I'm probably.
Okay, that's the question. Wait for a couple more. Okay, don't worry, there'll be more. Okay. Actually, I think, is this live? This might be live. Okay. All right. Okay. All right. Okay. So it's false. So good. We're here to learn. All right. Great. All right. Okay. So mitochondria, so the mitochondria itself, you need both your nuclear and your mitochondrial DNA to make up components of the mitochondria. So it's different when we're talking about the DNA that is in the mitochondria, and then the proteins that that are required to build the mitochondria. So here's a cool video of one of, so when you look at your textbooks, you think about that bean shape with the little cristae on the inside. So there's not just one per cell, this is actually a network of organelles of hundreds of them interconnected, and at oocytes you have millions of them. So there's about 1,500 nuclear mitochondrial genes amongst all of our 23 chromosomes, and the mitochondrial DNA encodes for 37 genes, so that makes only 13 proteins. So you need a lot of your nuclear DNA to make up the proteins that build the mitochondria. So that's important when we talk about the genetics later. Right, and so there's a cool picture taken by one of our collaborators on campus. As a reminder, again, we're going to go through AP biology here. So there's a picture and a zoom into the respiratory chain that is important for oxidative phosphorylation. So when, the main function of the mitochondria that we all learn about, and that's important when we think about human disease, it's as important for making ATP for cellular energy. But also does a lot of other things. I'm biased, but does everything. It's important for calcium homeostasis. And if you think about all the foods that you eat and nutrition, it essentially metabolizes and interconverts most things that we eat. So it's quite important. And any of these parts that break down will cause a problem with how your body functions. It also participates in self-reproduction and fusion and fission. It's important in aging and apoptosis and this cellular stress signals. And they make free radicals and radical species in scavenging, which you'll probably hear in the news or in the context of chronic disease. And then, of course, it also participates in humoral immunity. All right. Okay. So that's it for the basic science. All right. Okay. When we talk about human disease, for mitochondrial disease, we'll kind of break it down into two camps. So today we're mostly talking about primary mitochondrial disease. So that means that these are genetically based mitochondrial dysfunction, and most of the disease genes encode for mitochondrial located protein. And these disorders are typically chronic to some degree, but they do present maybe in the acute setting or are stress induced. In the news or in other literature, when you think about maybe more adult diseases, you'll hear about secondary mitochondrial disease. So there's no problem with the encoding or genetic encoding of the components of the mitochondria, but over time, either due to aging or diseases or environmental stressors, you may induce mitochondrial dysfunction and cause kind of early problems with how the mitochondrial functions. So we'll focus on primary mitochondrial disease. So this is the ancient bacterial DNA. It's circular, 37 genes, 16,569 base pairs. It's circular. It is a double-stranded DNA. There are no introns, no homologous recombination or meiosis for mtDNA. It does replicate on its own, has a high mutation rate. The way it edits itself is not as elegant as the nuclear DNA, so it does make mistakes. It has 13 protein encoding genes, 22 tRNAs, 2 rRNAs. So there's no common biomarker for all mitochondrial disease. It's a heterogeneous group of disorders. But later we'll talk about some of the biomarkers that we check to tell us whether or not there could be a mitochondrial dysfunction. The epidemiology is a little bit hard because it's a rare disorder. What's cited in literature is about 1 to 4,000 or 1 to 5,000. There's now more than 350 different genetic disorders described associated with mitochondrial disease. And it's mostly nuclear DNA changes, okay, and then mtDNA. And they are components that mostly comprise of the oxidative phosphorylation subunits, but also other parts of the mitochondria. And if there's a problem that doesn't, part of the mitochondria that's not working, then it leads to multi-organ failure. So these patients can get quite sick. Sorry about the order of these. So the important thing here is that the inheritance pattern, if you graduate, I just want you to learn this slide, okay? The inheritance pattern for primary mitochondrial disease can be due to nuclear gene defects, which actually explains more about 2/3 of childhood onset disease. And they follow all patterns of inheritance. Most of them are autosomal recessive. There's some that are autosomal dominant, some are X-linked, and of course, de novo mutations can happen. And then about 1/3 of childhood disease is empty DNA gene defects. We'll go over some of the common ones. The adult onset or early adult onset disease are more shifted towards mitochondrial DNA mutations. And then sporadic deletions, may not have a clear family history, but that can also happen. So this is a graph of one of our genetics disorders called Polgamma. But if you just remember how the slopes of the lines go, it kind of goes how childhood and adult onset disease happen. So in the less than 20 age, you can see that's mostly green, which is mostly nuclear DNA defects, and then the shift towards more empty DNA gene defects as that present a little bit later in life. So we'll go with our second poll question. Mitochondrial disease with empty DNA defects have a wide range of phenotypic variation even within the same family due to this fundamental concept. So I will advance to this one. So is it incomplete penetrance, heteroplasmy, mosaicism, or epigenetic modification? I think actually. Is it live for the next one? Is it live for the next one, or should I wait for this one then? Don't remember. I don't know if it's like a live poll.
Yeah, I mean, is it?
Yeah, I just don't want to advance before. Yeah.
Yeah, go ahead.
Yeah,
Yeah,
okay.
Once you advance, then it closes the poll.
Oh, okay. Okay. All right. Great. All right. So heteroplasmy, that is correct. All right. So this is the concept of heteroplasmy. It's different than mosaicism. So on the left, you can see, so we're now talking about mitochondrial DNA. All right. So the 37 genes one. All of our mitochondria comes from our mom. So all our mitochondria is in the oocytes, and every oocyte has a slightly different distribution of the mitochondria. And if there's something that is passed on in the maternal lineage, each of the oocytes have a slight different distribution of the pathogenic mutation. So in green, you'll see that they're wild-type mitochondrial DNA, so meaning that empty DNA that does not have the pathogenic variant that it's carrying, and then the red are the mutant empty DNA. And then there's a bottleneck effect, which is kind of random, where you have one of the oocytes that gets fertilized to create the embryo. So each embryo, even within the same family, may have started off with a slightly different distribution of the mutant mitochondrial DNA. And then the embryo itself, further undergoes a lot of replication to form the different organs. So within the same embryo, that ends up becoming the same, fetus and baby. Different organs within that, within that fetus, developing child can have different distribution of the mutant empty DNA. So, for example, you can have one sibling that has a lot of brain disease because they have a high load of the bad mitochondria. And then another sibling may have their brain a little bit more spared, and a lot of the mutant mitochondrial DNA is concentrated in the muscle tissue. So that, and then if you have a higher load of the bad mitochondria pathogenic mutation, then you manifest disease. We think the threshold is around 70%, but it depends on the gene. And then if you have lower, let's say it's just 5%, there's a lot of good mitochondria to make up for that. So you may not manifest a lot of symptoms. Okay, so this is graduation key learning point number 2. All right. So the clinical presentation of mitochondrial disease can be, there's some converging concepts, but it can be pretty complicated. There's a list of acute or subacute symptoms that you might see that present in the hospital. They can present with metabolic crisis, encephalopathy, arrhythmia and heart blocks, a sudden onset of blindness, optic neuropathy, stroke-like episodes, and of course seizures. And then it's often accompanied by with some chronic symptoms as well. So growth failure is pretty common, developmental delay of varying degrees, progressive ophthalmoplegia, so that's difficulty moving your eyes, retinitis pigmentosa, which is a cause of progressive blindness, diabetes, constipation, cardiomyopathy, neuropathy, hypotonia, exercise intolerance, and cognitive change. Okay, that's why neurologists talk a lot. This is a lot of things to go over. Okay, so there's a patient reported a study actually out of CHOP where they surveyed patients and tell me about all the symptoms that you have. And so the average mitochondrial disease patient reports about 16 systemic symptoms. So again, a really long clinic visit. Okay, so the top symptom that they do talk about, though, this is important when we talk about treatment later, is they report constipation and gastroparesis. So your GI system is highly metabolically active, so it's things get slowed down or dysregulated. Neuropathy and ataxia, because when you have those symptoms, it impairs your ADLs quite a bit. So it's a top symptom that patients report. And then weakness and exercise intolerance. So your muscles are highly metabolically active, and if you can't produce enough energy to keep up with your activities, then you fatigue earlier than someone who has normal mitochondrial function. All right, so I'll go over a couple of cases. These are real patients of mine. So the first one is a 12-year-old girl who presents with 1 week of headaches, confusion, altered mental status. This was during COVID as well. So I was all geared up with my bunny suit. Okay, she was treated in an outside hospital for presumed autoimmune encephalitis, but she was given a couple of days of IV steroids and did not respond, so she came to our hospital. And during her hospitalization, she developed new onset focal seizures. So I know I'm a neurologist, and I have to show you an MRI, but you can tell that there's something not right here, right? Okay. Great. Does not take a neurologist to tell you that. So DWI is diffusion weighted imaging. So this is a sequence that we look at when when we think there's a stroke. Right. So the things that are white light up, so meaning that there is a problem with diffusion in that area. So that, left is right, right is left. So this is the right parietal occipital area. And then T2 flare tells you that there is some level of inflammation or disruption of the blood-brain barrier. So you can see that there's a correlating abnormality on the flare sequencing. So this patient got tapped. She had CSF studies and they were all negative. And then we actually sent the CSF lactate as well as the serum, and they were both elevated. So history is really important still. So we talked to her, and she's been short her whole life. They don't know why. And she was diagnosed with bilateral sensory hearing loss in the year or two leading up to her presentation. She also has a lot of migraine headaches that she kind of just sort of put off. And then the mom also said that she had some mild hearing loss and thought that was just a thing that people have. Okay. So we tested her genetics, and she has a pathogenic variant in the MTTL1 gene with a 32438G mutation. So this is MELAS, which stands for mitochondrial encephalomyopathy with lactic acidosis and stroke-like episode. So we call it MELAS for short. If you know what it stands for, though, it tells you exactly what these patients present with. So the 3243 variant is the most common, but there are a couple of other mtDNA mutations that also cause the MELAS phenotype. The spectrum of the phenotypes that present is linked to the degree of heteroplasmy. So again, the higher they are, the sicker they present, the earlier they present in life. So the really severe heteroplasmy levels present in early childhood with short stature, lots of developmental delay, a lot of seizures, a lot of stroke-like episodes, myopathy of varying degrees, and they can also have a cardiomyopathy. This is the one that I see more commonly. This is the category I put this patient in. She's in the modest heteroplasmy level. So they can be healthy until school age, and then they present with their first-time stroke or first-time seizure. And then they can have abnormalities on the MRI that tells us there's a metabolic problem. So involving the basal ganglia as well as the cortical areas. And they can have hearing loss and they can have seizures, which can be intractable. And then the lower heteroplasmy, these patients can be high functioning until early adulthood. So they have early onset diabetes. There's actually the MELAS, this mutation is actually responsible for a good percentage of early onset diabetes that goes undiagnosed. And then they can have stroke-like episodes later, and then they get progressive cognitive dysfunction. So it's important in these cases to inquire about family history that can really help you, hone in on the diagnosis. And these are the key things to ask about. All right, so not sure how familiar everybody is about this, but just going over a little bit on the basic science of the stroke-like episodes. I think it's involving the nitric oxide synthesis. So because there's a problem with how energy is produced, there's a compensatory mitochondrial proliferation in endothelial cells in the blood-brain barrier. And so that causes a microvascular angiopathy. And so causes a nitric oxide deficiency and impairs smooth muscle function. So on the right, you'll see a schematic. On the bottom is cyclic GMP. That's important for various functions of the vasculature. And then upstream of that, you'll see NO, that's the nitric oxide. And upstream of NO, the production of nitric oxide uses arginine as well as citrulline even more upstream. So arginine and citrulline, as I'll briefly mention later, is our treatment for stroke-like episodes. All right, so case 2, this is a 2-year-old who presented with developmental regression after respiratory illness. Birth and early development were normal, and the parents reported that he suddenly stopped walking and his language acquisition halted. And his neuro exam, I will gloss over, was abnormal. And his MRI brain showed, so again, you don't need a neurology training for this. The white stuff is abnormal. This is symmetric T2 hyperintensity of the diffusion restriction of bilateral basal ganglia. All right, so subcortical structures, and that extends down to the brainstem and dentate nuclei and inferior medullary olives, so all the way down to the brainstem. And if you did an MR spectroscopy, there's a lactate peak. So this is a normal output for a spectroscopy. If you can look on the, I'll point this out. The bottom here is the ppm. So you need to move it over to the other screen because we're not seeing everything. Oh, okay. That's okay. I'm just gonna tell you. So there are various numbers on the bottom, and there's a normal pattern to spectroscopy when you do it, and as human brain. So there's normal in the upslope of the different peaks.
Okay, there it is. So now we're moving it. Okay, there it is.
Oh, okay. Okay, great. Okay, all right. Okay, so normally there's an upslope over here, and then 1.3, this is where lactate peak. So these are bunny ears at 1.3. Normally, if there's no lactate peak, this is all downsloping. You don't see this peak, all right? Okay, so he had material whole exome sequencing, and he had a compound heterozygous variant in the SIRF1 gene. So this is Lee syndrome. In the past, we called this subacute necrotizing encephalomyelopathy due to the pathology imaging. So this is one of the most common pediatric mitochondrial disease. It typically presents in infancy overall with a pretty poor prognosis. So they have a sudden developmental regression, irritability, vomiting, seizures, and eventual other organ failure. Interestingly, these patients tend to present after some sort of immune trigger. We love it when it comes in after a viral live vaccine, but does that happen? And then more commonly, actually, with a viral illness, and they get really sick. So the MRI that I showed you has the typical findings we see in Lee syndrome, and then often you'll expect a lactate peak in the area that's affected. There are a lot of genes that are associated with Lee syndrome. So there's 113 actually for our next slide. But this is just an image from one of our papers from the North American Mitochondrial Disease Consortium from a couple of years ago. So it just kind of shows you a concept that you can see that there are a bunch of genes, and it's a Venn diagram, right? So there's overlapping phenotypes. So when we talk about the genes, there are some genes that can present in different patients with different clinical syndromes. So where some of these Venn diagrams overlap, when you find a mutation in someone, you also want to match it to their clinical phenotype. All right. There is a treatable metabolic disorder called thiamine transporter or biotin and thiamine responsive basal ganglia disease that can have a similar MRI finding. And it is quite treatable with high dose biotin and thiamine. So just remember that it's it's something to look for and definitely picked up on genetic testing. All right, so there's probably more genes in this, but currently about 113 genetic causes. This is a nice paper with a lot of work going into gene curation. So, I welcome you to take a look after this talk if you're interested. If you suspect Lee syndrome, please look at the nuclear DNA as well as the mitochondrial DNA. So, if you can get an exome, if you're really fancy, you can get a genome. And then usually the genomes will actually sequence the mitochondrial DNA as well, or you can get a panel where you get an exome and a mitochondrial DNA. Okay. I won't belabor this. We're doing prospective cohort study to really get a really good natural history on the spectrum of Lee syndrome that we're doing at a couple of different centers. So you need really good natural history if you actually want to cure the disease and come up with a meaningful treatment. All right, I'm gonna skip over this actually. So you can ask me about neuroinflammation later. We can talk about that. All right, case number 3. So this is a 2-year-old who's evaluated for slow weight after birth. She had global developmental delay, predominantly in the gross motor and language domains. If you remember your milestones, 33 months is very late. Okay. And then talking at 15 months is borderline. And so she's able to jump, but she has got some progressive spasticity. So again, more MRIs, the white stuff is abnormal. Okay, so on the left is the brain. She has bilateral white matter changes that looks like a leukodystrophy. And on the right, I'll show you over here. Spine is always a little tricky, but there's a whole column of white going down the spinal cord that looks like a longitudinal transverse myelitis, but it's actually not. It's a leukodystrophy. So she had whole triome exome sequencing as well, and she's got pathogenic heterozygous variants in the DARS2 gene. All right. So DARS2 encodes for the mitochondrial form of the aspartyl tRNA synthase. These biallelic pathogenic variants cause a disorder. It's an autosomal syndrome called LBSL, leukoencephalopathy, brainstem and spinal cord involvement with lactic acidosis. Also a mouthful, so we call it LBSL for short. So these, because of the progressive white matter changes, they get progressive cerebellar ataxia, spasticity, and a lot of spinal cord issues. And the MRI, this is atypical for many other mitochondrial disorders. So you see this, you do think about this group of disorder. So what are tRNA synthetases? So these are a group of enzymes that are, the main function is to amino acid or charge the tRNA with their cognate amino acid. So that's that part of that's required for protein production. These enzymes are encoded again by the nuclear gene. All right, and then once they're made, they're translated in the cytosol and then transported into the mitochondria if that's where they live, and they're important for charging the amino acids in the mitochondria itself. So there's 37 human ARS genes, 18 encodes for cytoplasmic, 17 is mitochondrial specific, and then 2 that do both. These disorders are autosomal recessive, and there are, this may be a little bit outdated, there are a lot, it's like an alphabet soup within an alphabet soup of mitochondrial disease. There are a couple of genes that are more associated with epileptic encephalopathy, so present with early infantile onset, a lot of seizures, and then leukoencephalopathy, not a lot of seizures, but those white matter changes that I showed you. Don't remember all of these like different letters, but if you see the number 1, that is the cytosolic enzyme. If you see the number 2, that is the mitochondria. There's no number, it's the one that's both. Case number 4. Okay, this is a 15-year-old previously healthy boy who presents with acute painless onset of blurry vision and loss of visual acuity on the left, affecting his central more than his peripheral vision. 2 weeks later, he had the same thing in his right eye. these patients come to me, they're like, do you think this is an autoimmune disorder? Well, it does seem like it. So visual acuity of 2200 on the left, OS, that is really bad, 2100 on the right, and a dense central scotoma and no color plate. So this is a classic optic neuropathy, but it was painless, all right? And then his fundus exam showed that there's optic nerve head edema, as well as some retinal vascular tortuosity. So here's an example of picture of the fundus. You can see that you don't see a nice little cup in the back. It's quite swollen. We imaged him and his MRI brain and orbit and the cervical spine were all normal. And the antibodies that we typically see in the autoimmune optic neuropathies were negative. And on further family history, again, talk to the families. There's a similar symptom in the maternal uncle as well. So this is Leber's hereditary optic neuropathy, often mimicking an autoimmune disease. There are a couple of other variants, but these are the top three, the 11778, then the other two variants are the most common three mutations associated with LHON. But there are plenty more that are reported, and I'll show you a little bit later. The 11778 being the most common variant is the variant that they've developed a gene therapy for. All right, so the males are 4 to 5 times more affected than females. We're not really sure why that is the case. And there is a subset of LHON plus syndrome where they do have abnormal MRIs that kind of look like MS plaques. And then they can have also systemic involvement. So more than the eye, they can have tremors, peripheral neuropathy, myopathies, and cardiac arrhythmias. All right, so the diagnosis is to do their mtDNA sequencing. Most of these are, as you can see, mitochondrial DNA problems. And then the treatment is adepanone, which is a form of CoQ10. This is approved by the European group EMA, but not by us. So here we give them high dose liposomal ubiquinol and talk to them about lifestyle factors. And then more recently, if they the therapies are closed, but there may be upcoming gene therapy for this. Alcohol and smoking is bad for you in many reasons, but it's also really, really bad for your eyes. So when you talk to our patients, you want them to avoid as many environmental triggers that cause mitochondrial dysfunction as possible. All right, the next syndrome we'll talk about is mitochondrial deletion syndrome. So the pediatric one's the one that you'll learn the most. So that means that, you see the circular mtDNA, you can certainly have, because it's not good at editing, there could be chunks or multiple chunks of the mtDNA that's missing. So that means a lot of the genes are gone as well. So that causes, obviously, problems with how the mitochondrial is made. The infantile onset is called Pearson syndrome, or now we call it single large-scale mtDNA deletion. I don't have it here, but they basically present with hematological abnormalities, and that can actually self-correct after a couple of years. Kern-Sayre syndrome is another one that is pediatric onset. It's associated classically with progressive external ophthalmoplegia. So again, your eye is not ptosis. So you got eyelid muscles, right? And then the eyes don't move side to side or not very well. And then cardiac conduction block, this is the thing that will cause, that's the cause of their mortality most of the time. And then they can have pigmentary changes in their eyes. And then back when we used to tap more people, they also have elevation of the CSF protein. So they have early normal development, and then they have short stature, and then they develop all of these other problems. The adult onset, we do see these as well. So lower heteroplasmy, again, they can have a history of short stature, deafness, and ptosis, but they can just have the ophthalmoplegia that's adult onset that's progressive over time. And then some of them may just have a muscle problem. So they just have a myopathy without all the other problems. So there's another group of disorders called the reposome disorder. So these are nuclear DNA genes that are responsible for the replication machinery of the mtDNA. Again, alphabet soup. Okay, so there's a lot of genes associated with this. In either literature or in test exams, you may have heard of polymerase gamma 1, 2, and then thymidine kinase 2, TK2 is the second one. Just to remember, there may be a treatment for that coming up. So these are mutations in genes that are responsible for editing the mitochondrial DNA. So if there's a problem with with one of these genes and how the mtDNA edits itself, then you get lots of multiple deletions in mtDNA. And again, if you have chunks of the DNA missing, then you can't encode for certain proteins. So the symptoms may vary depending on the gene, but these are the ones that we see in reprosome disorder. So they can have a myopathy and exercise intolerance. They can have progressive external thaloplegia in these ones as well. Ataxia, sensory neuropathy, and then with POL gamma, there's an infantile or childhood onset severe phenotype called Alpers-Hurtenlager syndrome, associated with seizures, liver failure, cardiomyopathy.
I want to mention the NPV17 you talked about.
Mhm.
Navajo neuropathy. So important to know because we see a lot of newborns with liver failure.
Mhm. Yeah, so Dr. Gravy said, just into the mic, the NPV17 has a founder mutation here, so called Navajo neuropathy. Okay, all right. We'll call it NPV17 associated neuropathy. Okay. Yeah. Okay. All right. So I'll skip over this too, but there's some work with our campus collaborator. She's a PICU attending actually. So looking at some neuroinflammation mechanisms, POL gamma. So TBD, when hopefully if I come back in the future, I'll give you more information on that. Okay. Another phenotype that you'll see is called NARP, so neurogenic muscle weakness, ataxia, and retinized pigmentosa. And then you will see actually, yeah. So on the bottom there, you'll see the 8993 is the most common mutation. So these present in early childhood, sometimes in adulthood as well. Global developmental delay, hypotonia. You see, there's some themes here. They present with quite elevated lactate, CPK, which is a muscle enzyme, abnormal urine organic acid nasocarnitine profile. And so it's in the ATP6 gene, and the 8993T, the gene mutation is the common. There are some patients who just have the muscle weakness, ataxia, and the eye symptoms, but they don't have a lot of brain burden. Some patients have a lot of these symptoms, but they also have all of that Lee syndrome looking MRI changes. So it is kind of a spectrum. And some of these patients are actually in our Lee syndrome natural history study. The severity of their clinical phenotype, again, is linked to the heteroplasmy. But these patients tend to have really, really high heteroplasmy loads when they come in like near 100%. So that's the end for most of the more common clinical phenotypes that we see in mitochondrial disease. I could probably go on forever, and you don't want me to. So there's a lot more, so I'm happy to answer any questions that you have if I've not covered it. So these are just kind of some highlights of what would be a red flag for me for mitochondrial genetic disorder. So it's important to know that when we think about genetic disorders, you think it's something that's chronic and slow brewing of some sort. And that is true if you get some of the history. But these disorders can also present acutely, right, in the hospital and that sometimes could be the first time that they present with the disease. So either with a seizure, strokes, or encephalopathy. So some clinical red flags. So if they present acutely, but they also have some other symptoms that are chronic or progressive in nature. They have had a sudden developmental regression preceding some kind of presenting event or viral illness, immune trigger. A positive family history, again, talking to the family, and then any other organ involvement. So diabetes, sensory hearing loss, cardiomyopathy, GI dysmotility being the most common ones. And then for the LHON spectrum, if there's a rapid bilateral vision loss that does not respond to immunotherapy without any other evidence of a neuroinflammatory disorder, think about Leber's. MRI red flags, if there is symmetric confluent white matter changes, so there are other leukodystrophies that are not mitochondrial in nature, but if you see that in general, you want to genetically test them. Metabolic strokes, and then any evidence of elevated lactate on MR spectroscopy. Diagnostic red flags, if you think this is acute onset, then you tap them and it's completely bland. That is a red flag for something that's not inflammatory. And then CSF lactate in particular, there aren't a lot of things that elevate your CSF lactate. So you can have infections, certainly can do that. And then some kind of metabolic disorder. Okay. So again, just reiterating acute decompensation after immune onset, and then you created a lot of lactic acidosis, and then you see all these paraclinical symptoms of a metabolic disorder. And yeah, that's pretty much it. So diagnostic testing. So when we diagnose patients, there are a lot of different things. We have to look at their clinical symptom. We have to examine them, talk to them about their family history, and then we get some tests. So there are blood, urine, and CSF testing that can be helpful. And then the organ evaluation is to see if they're what are involved. So of course, with brain MRI, MR spectroscopy, looking at the heart, looking at their ears, looking at their eyes. And then, in this day and age, we jump to molecular genetics quite a bit. So in an ideal world, you can look at least their exome, along with the mtDNA. There are panels out there that I'm sure Dr. Gravy talks to you guys about. And then we can also look at different tissues, again, with the heteroplasmy to see, for evidence of a mitochondrial dysfunction. So here is a list. If you want to take a picture, go ahead. Here's a list of all the different things that we test for. So I'm just going to go over a little bit. So a lot of these things are done clinically. So step number 1 and 2, if you see someone presenting in the patient and someone in the hospital that you suspect has a mitochondrial disorder, here the testing in black are the ones that we typically send clinically. The testing in blue are some research-based testing that I can't tell you if they're quite helpful yet. And some of them are, commercial available. A lot of them are in research labs. So, CBC, the typical CMP, CPK, lactate, ammonia, but also amino acids, isocarnitine, free carnitine, organic acids, and thyroid and A1C. Genetics, again, we talked about, ideally you would look at as much of the nuclear DNA as you can and the mtDNA. Blood is the least, in most of the mitochondrial diseases, blood is the least sensitive because there's turnover of the leukocytes in the blood. So sometimes if there's a low heteroplasmy or if it's negative from blood mtDNA, we will send a buccal swab. So the cheek swab is a little bit more sensitive. And GeneDx also has a urine sediment, which is even better. That is, if you have one mutation, they can actually sequence that. And then sometimes if patients really need a muscle biopsy, you can also sequence from the muscle. You can also sequence from every organ if you want. Some of these patients get liver biopsies, so you can also sequence from the liver. All right. So if the genetic testing is unclear or negative or inconclusive, but you're really convinced that they have a mitochondrial disorder, then you can do biopsies, looking at their muscle, and then do some fancy new functional studies that we're doing. So because this is a cool video, I'll show you. This is it's called a 4D lattice light sheet imaging. They're about 3 in the world or something like that. So this is my collaborator who took some pictures of my patient's fibroblast. It's a staining for mitochondria. So green is the mitochondria, and then red is the kind of the cell surface. So you can see that there's a network, and what you can do is actually take 3-second imaging of these plates of cells and do some fancy AI stuff with it. Okay, so he's a smart guy. All right, so what we did is he's actually taking a lot of my patient samples, but we did DARS2 and SURF1. So the 2 patients I showed you earlier, we grew out their fibroblasts and gave it to him and took some pictures. And so each of these threads are a mitochondrial network. So there's a lot, in per cell. So what they do now, or what he can do now, is actually take those threads and make them into linear programming. And then you can map over time in frames where these mitochondria is going, whether they are breaking, whether they're going to a different place. And so, some upcoming technology using AI tools to tell us about mitochondrial function. All right, so go over a little about treatment landscape, and this will kind of be the end of our talk. So our last poll is, so all of the following are important considerations in therapeutic trials for mitochondrial disease, except successful clinical trials rely on solid understanding of natural history. Small numbers of total numbers of potential patients make trial recruitment challenging. Mitochondrial disease is homogeneous, making biomarkers and outcome measurements easier to select than other rare disorders. Mitochondrial disease can be life-threatening, making randomized controlled trials designed with placebo ethically challenging. I'll wait for a couple more. There's more reading for this question. I love those accept questions and you're like, oh shoot, I picked the right one. Okay. Go. All right, good enough. All right, fantastic. Okay, I did a really good job writing this question. It's kind of a freebie. Good. All right, very good. Yes, they are heterogeneous and biomarkers are not great, and clinical outcome measures are really challenging. All right. Where is Dennis? Dennis has 100%. Is Dennis online? Okay, good job. All right. All right, treatment is multidisciplinary. All right, so I am the neurologist on the bottom, but I need a whole team. I have a lot of other collaborators who really need to take care of these patients. Primary care is super, super important. They can be the champion for these patients. So you're going to go out and do community primary care. We're very, really needed to recognize these disorders. If they have obviously endocrine problems, diabetes, and endocrinology, GI, cardiology, genetics, very important. Genetic counseling, that work a lot with the genetics clinic are really important, talking to these families. And then, for developmental needs and therapies, rehab medicine, and then eventually, some of these patients need early palliative care or social services. And then hopefully somewhere down there, we can put disease modifying therapies. So currently there's no FDA approved therapies given individually rare disorders, but that may change in the next couple of years. When we talk to patients about their kind of day-to-day stuff, exercise is actually really good, but it's hard to, even without mitochondrial disease, in residency, it's really hard to get yourself to exercise. All right. So if you have a problem with how your muscles already move, it's really hard to get started exercising. But aerobic and isotonic exercise is good for you. So we tell them, if you can, body weights or some weightlifting exercise can actually shift the heteroplasmy to wild type. So somebody actually did that study. So that's what we tell them. And there's a packet of PT exercises that we give our patients to work with their physical therapist. Nutrition there's a limited guidance for it. It's under recognized. There are certain mitochondrial disorders like pyruvate dehydrogenase complex disease that specifically requires like a ketogenic diet. But in general, there's not a special diet for mitochondrial disease. Mostly that the pediatric patients have failure to thrive. So have them work really closely with GI nutrition to optimize their nutrition. This is a nice paper as well. If you want to take a look at it, or just take a picture of this nice figure that they made. If you've come across some of these patients, they may come with like 20 bottles with supplements. So the core medicine regimen that we recommend for patients, although with limited, if any, level 1 evidence, is a B complex vitamin that they sell at B50 or B100. So that has all the different good B vitamins that you need. So it's kind of all in one type of thing. And then CoQ10, which of course feeds into complex 1. Ubiquinol is the more bioavailable one. So that's the one you look for on the bottle for these patients. And then some sort of antioxidant or vitamin E or alpha lipoic acid. And then what these authors did a really good job in is they kind of broke it down a little bit by the different symptoms or syndromes that patients may come with to consider additional supplements that may help them. All right, so the middle is stroke-like episodes are probably like the mean loss phenotype. So we give arginine and biotin, thiamine, and citrulline. This is something I did a couple of years ago. We do have emergency care guidelines for patients. So not all patients live close to an academic center. So what we do is give them a letter describing what genetic mutation they have, what they're at risk for, and when they come to the ER, what to do about them. So either the ER here or any other ER when they travel or when they go to a community hospital that may not be really familiar with their disease. So I pulled the NEMDEC consortium, which is centers across the US, to basically give me their institutional protocols and I put it all together. And it's a long document, but there's a shortened version for patients, but for ER, and there's also some guidelines for surgery, anesthesia, and medication use. So if you're interested in that, I'm happy to share that with anybody. For strokes, for MELAS, you want to identify the precipitating factors, and then you want to get an MRI stat, and then this is the dose of L-arginine that we give. It's 500 milligrams per kilogram. I don't usually give the first bolus. I usually do the 500 milligrams per kilo divided Q8. You can give that daily for about 3 to 5 days. There's limited guidance for after 5 days of how helpful it is. And then if they're not on it already, you want to start them on their home arginine. And there's also citrulline that you can also give them. It's important that LV arginine does not work like TPA for ischemic stroke. So it does help with, in some observational studies, to improve long-term survival or to shorten hospital stay, but it doesn't, these patients would still be in the hospital for quite a bit, needing a lot of supportive care. Anesthesia, most patients can actually tolerate anesthesia. There's some patients who tell me that they've been told to never undergo anesthesia ever again. That's not true. If they need a procedure, they need to do it. Okay. But we try to tell them to, there's a guideline to avoid volatile anesthetics, and short-term exposure to light anesthesia as much as possible is suggested, as most anesthesias are toxic to the mitochondria. There's a thing called propofol infusion syndrome, which leads to severe metabolic decompensation in some mitochondrial patients. I've seen it before. It's really scary. But if you can give propofol, but I try to limit it to at most an hour or two. And then elective procedures should be postponed if any signs of infections and to avoid prolonged fasting. So we request that if elective surgery to really plan it earlier in the day if they can. All right. You guys got it right, so I won't talk about the challenges of clinical trials. So this will be our last slide. So there's a couple of clinical trials that have completed or are ongoing. This first one has completed is the PPR delta agonist peroxisome proliferator activated receptor delta modulator. So these were just targeting myopathies in adult patients, so it didn't meet primary endpoint. Like I said, our clinical measurements may not be as sensitive as we want. Alamiprotide is one that just closed. It's a aromatic cationic tetrapeptide that binds to cardiolipin. So that one we did a trial for reposome specific mutation. So that study result is pending. And then in Europe, they're usually actually like an immune modulator, sphingosine 1-phosphate receptor modulator. And then there's one that we are hopefully starting soon, which is a NAD stimulator with this compound KL1333. Other things, so this is the TK2 treatment. So this is basically giving back nucleosides for this disorder. There's currently an expanded access for TK2, and they're undergoing expedited review in the FDA right now. There's a gene therapy for the 11778 LHON that has just completed with some 5-year results. There's an ongoing one we're doing at our trial, at our center for MELAS, for zigozigod. It's a phase 2B, looking at cognitive function. There is one for Pearson syndrome, which is actually in autologous CD34 hematopoietic stem cell. And the cysteamine for MELAS that's pending, currently working on Europe. And then there's another one that one of our, our other centers is working on, which is basically looking at a better version of CoQ10. And then coming down the pipeline is there's very possible a 3243 MELAS gene therapy, which is very exciting. Very cool biology if you want to ask me about it later. Right. Okay. So I want to thank, that is it. And I want to thank all my clinical research teams and collaborators. Here are some resources if you want to look up either the genes or looking at the diseases. And feel free to visit me in San Diego. All right, and I have to stop at this slide so you guys can get CME. Any questions? Yes, go ahead.
So my name's Wendy Bernatovich. I'm a division chief of Gen Peds, board certified in palliative care medicine as well. And we run a complex care clinic. So we have lots of your patients. A cohort that we see that's really challenging to care for are some of those patients who don't have genetic evidence that they have mitochondrial disease, but they present with GI dysmotility, POTS-like syndrome, and they've been on TPN for like when they're little, and as they grow older, they sort of outgrow their problems. And so it's really challenging because we can't always figure out what their mutation is, and they'll often go around to specialists to try and figure it out. I didn't know if you see patients like that. Like, do you see patients that can present in this sort of like subacute, sort of not having all the MRI differences or eye changes, but have more of this GI dysmotility and POTS-like syndrome?
I have a lot of patients with mitochondrial disease who have that and also other things. Obviously, I have certainly a small chunk of my practice is, I don't know what it is that you have, but I may be the closest thing of someone who can maybe help you through some of your symptoms. Some of the genetic link for mitochondrial disease, they can have some autonomic dysfunction. So particularly the adult MELAS patients, actually, I got a good chunk of them who actually have like POTS-like things, but I think it's like, just problems with their autonomic nervous system. So in those cases, I'm sure you guys have an amazing geneticist here, but, sometimes we do the best that we can do and still don't find an answer. In general, if we're looking for empty DNA, I try to look for other tissue samples to see if we can sequence it in a different tissue. So this may be a case where I would go for a muscle biopsy and do some functional studies just to kind of give some additional evidence. That other bucket of secondary mitochondrial dysfunction, there are some kids where, like, if I did biochemical testing, there's some abnormality with it. I don't have a molecular diagnosis, but sometimes I may put them on some of these supplements to see if it, helps them feel a little bit better. Yeah. They're not harmful, so yeah. Yes.
One quick one in the chat. Can any of these mitochondrial diseases present in adulthood, or are they evident by adolescence?
So as some of these genetic disorders can present in adulthood. By adulthood, I mean not like early adulthood. So MELAS with so in adults, you see actually more empty DNA mutations and at a lower degree heteroplasmy in general. There's always exceptions to the rules. So MELAS, again, that 324(3) variant, it actually explains like a good chunk of early adult onset diabetes. So yeah, certainly I will see new consults of patients in their 20s, 30s, 40s, 50s.
Another one in the chat. Can you comment on the urgency of diagnosis of mitochondrial disease, given that it may take months or years to recognize and get into the appropriate specialists?
Yeah, I think that can be hard, right? So there are many reasons that I put on my list of justifications for genetic testing quite a bit. So, if there are actually helpful disease modifying therapy, that is a really easy justification to be like, hey, I want to recognize as early as possible and diagnose as early as possible. Right now there's not like a amazing DMT for mitochondrial disease. So that rationale is not as helpful right now. But for a lot of these patients though, it's not just like, oh, I want to get into a treatment that's going to cure me. For them, it's been, it's very psychologically stressful for several years for their families. And I think just knowing the answer and ending a diagnostic journey is a big part of kind of that feeling of satisfaction that somebody, kind of took the time to really help them come up with an answer as to why they had all these symptoms. And then actually, if they have a molecular diagnosis, then it's easier to get them into the subspecialty care that they need. And then if they have a molecular diagnosis too, is we do routine cardiac screening. A lot of the cardiac stuff is the thing that will cause them to have a sudden problem and be hospitalized. So then we know, okay, then I need you to see the eye doctor once a year. I need you to see the heart doctor, et cetera. So.
Lastly, if a resident's on the wards and we see a kid and we think maybe there's a lot of stuff in a lot of organ systems, maybe this would be a good, could it be mitochondrial? Is it referred to genetics? Is it referred to neurology? Both? And at what point will there be a role for non-geneticist, non-neurologist to order this testing?
Yeah, so I'm learning that this is very hospital dependent. I am strongly in favor of the more that we can, that's why I'm out here, the more you're educated, the more you're empowered to know more about this so you can do it yourself, right? There are some institutions where genetic testing is, because you have to do also the appropriate counseling as well, is done within genetics. And so it does tend to be guarded by genetics because of all the components required of genetic testing. At our institution, we have a genome institute, you know. So there's a program with our genome institute where with really critically ill children, we can nominate them for whole genome sequencing. And so there's a representative per division that partners with the genome institute. So any of those subspecialists could nominate a patient and get sequenced that way. And they get a GC through the Genome Institute. So our neurology department orders a lot of genetic testing. Yeah.
And then maybe we'll let Dr.
But the answer is everyone,
Yeah.
eventually.
Let's let Dr. Greeley comment on PCH, and then we need to get the residents back to the work.
Yeah. Yeah, I would say it's appropriate to consult genetics. I mean, if it's in the very acute setting, we might need a rapid West. So right now we are doing those. They take authorization free off in the hospital. We get the results in 1 week, so that's great. Not your 48 hours, but in a week.
No one really, yeah, those are for really.
Setting, I think we can see them in the clinic, and that's a different matter. But I think as you said, they need to see both neurology and genetics.
Mhm.
And when
Good. Well, thank
Yeah.
you.
Okay, thank you.